everyone, welcome to NURSINGMANTHRA. Hope all you are keeping well. I was on vacation, that's why past month I couldn't upload my videos. So as a continuation of our videos, today we are going to the main topic, that is nervous system disorders. The first nervous system disorders we are going to discuss regarding the spinal cord injury. So we can go through the spinal cord injuries. There are mainly two types of spinal cord injuries that we are saying, like complete and incomplete spinal cord injuries. So each one according where the area is affected, based on that we are the patient will be having different problems. So we can go through the complete spinal cord injury. What are the areas affecting, which nerves are affecting, how the patient's body system is affecting, we can see that. So now we will go through the complete injuries. What are the complete injuries? So based on the vertebra where it is affecting, it will be problematic to the patient. So first one, we are going to see injuries to the C2 and C3 level. C2 and C3 level, if there is any injury, it will affect the phrenic nerve. So phrenic nerve damage, it will leads to the which supplies to the diaphragm. So which area is affecting? Diaphragm, if it is affected, the respiratory system is affected and it is more fatal. And next is injuries to C5 to C8. If there is any injury to C5 to C8, it will be affecting the nerve supply of intercostal muscles. So that also, intercostal muscle also helps for respiration. So respiratory management we have to do in this. So the main management is oxygenation. So maintain the saturation and check for loss of consciousness or level of consciousness, everything. So next we can see what are the complications in the cervical vertebra if any problem is there. So first complication we can say quadriplegia or like tetraplegia, quadriplegia or tetraplegia. That means it will affect the four limbs, upper limbs and lower limbs. Usually in the MOH questions and all, they will be asking what is paraplegia, what is quadriplegia, what is tetraplegia, and they will be giving different options. We will get confused what it is. So tetraplegia or quadriplegia is it affects the four limbs, upper limbs and lower limbs. And if the injury is in the C4 injury, if it is C4 injury, there is a complete paralysis below the neck area. So C6 result in partial paralysis. That means paralysis in the shoulder area and the lower body. So that is C6 injury. If it is affecting, it is a partial paralysis below the neck, like a shoulder area and the lower body. C4, it is just below the neck, complete paralysis. I hope you understood regarding these complications. And next we are going to, so we finished regarding the cervical injuries. Any cervical vertebra, any injury, vertebral column injuries, what are the things happening, we have seen that one. So next we will see what is the thoracic injuries. If anything happened in the spinal cord, thoracic spinal area, so from T1 to T2, the complication is paralysis. That means paraplegia, paralysis below the chest. That is paraplegia, paralysis below the chest, if any injury in the T1 to T2 level. So then injuries above T6, that will leads to autonomic dysreflexia, especially in the T5 to T6 level. So it will leads to autonomic dysreflexia. I hope that you heard regarding autonomic dysreflexia. So if some of you are aware about the autonomic dysreflexia problem. What is autonomic dysreflexia? So autonomic dysreflexia, there will be a severe throbbing headache will be there, and due to the hypertension. There is some stimulating factors for that. Due to the stimulating factors, the triggering factor will be there. Because of that, severe throbbing headache will be there. That the level is above T6, T5 to T6 level. And what are the stimulating factors or triggering factors we will see here. If there is a full bladder or any fecal incontinence, constipation, or any restrictive clothing and any pressure areas, all these are the stimulating factors or triggering factors for autonomic dysreflexia. So you can expect a question from this point, like the triggering factor. The patient is having full bladder or in fecal incontinence, okay, and suspected the injury, like a vertebral column injury suspected. What are the below mentioned disease which will be more chance to get? So in that, autonomic dysreflexia will come. So like that the questions they are asking. So here the stimulating factors are full bladder and fecal impaction, restrictive clothing and pressure areas. These are the things which trigger the autonomic dysreflexia. So if there is a full bladder, you have to give the urinary catheterization, or fecal impaction, you have to give the laxatives, stool softness, and restrictive clothing means you have to lose the clothing, and pressure areas maximum try to avoid it. Okay. So what are the clinical features you can see in autonomic dysreflexia? So there will be flushed face and nasal stiffness will be there, and the sweating will be there, blurred vision will be there, and piloerection, then heart rate will be decreased. So these will indicate like there is a vasodilation is happening, occurs above the level of injury. So vasodilation, clinical features are flushed face, nasal stiffness, sweating is increasing, pulse rate is decreasing, and blurred vision, piloerection. All these symptoms are for there is injury occurs above the level, the vasodilation occurs above the level of the injury. And if vasoconstriction occurs below the level of injury, means there is a vasoconstriction is happening. So vasoconstriction, part of the clinical features means there will be pale and cool and clammy skin, then there is no sweating you can find out in this vasoconstriction. So the management for autonomic dysreflexia, we have to provide the high Fowler's position and or sitting position. If we have to assess, always we have to assess the bladder distension. If bladder distension is there, as I told before you, we have to put the urinary catheterization. And if there is any fecal impaction, we have to give the stool softness and the laxatives. Then we have to avoid the tight clothing and management, because we told already it is due to the hypertension. So we have to provide antihypertensives, that is the medical management for autonomic dysreflexia. The main important thing is you have to avoid the triggering factors. That is the main important management. So if any question asking regarding the autonomic dysreflexia, I am sure that they are asking regarding the stimulating factors or triggering factors. So what is the management for that? I hope you all understood regarding the autonomic dysreflexia. So let us see what are the, if the injury it is happen in the lumbar area, lumbar or sacral nerve injuries. So what are the things is happening here? So if any injury is happening in the lumbar area, the paralysis of the lower extremities is happening, both lower extremities. That is paraplegia, we are calling the term as paraplegia. So if the injury is at the S2, S3 level, it will lead to neurogenic bladder. This kind of questions also can be asking in the DHA exam. So there is an injury in the S2, S3 level, following which which condition can be affected like this, that is neurogenic bladder. So what is neurogenic bladder means? Bladder will contract, we will feel to urge to urinate, but the bladder will not get emptied. Little urine will be going out, but it will not be getting emptied. So that is neurogenic bladder. If the injury is above S2 level, if it is above S2 level, in males there will be erections will be there, but there is no ejaculation is happening in the males. And if it is between S2 and S4 level, there is no erection and no ejaculation is happening in males. That is the problems happening in the S2, it's above S2 level and between S2 and S4 level. So now we can see the complete management for the spinal cord injuries. The main management, most of the time in the questions they are asking the log rolling technique. Like a log, we have to roll the patient. Okay, for turning the positions or changing the bed sheets or for transferring also, we have to do the procedure like log rolling. Like a log, we are rolling the patient. So, and also we have to follow the jaw thrust maneuver to open the airway. If there is any spinal cord injuries, you all are working in emergency departments and all, so you will get a patients with the RTA patients and all, you are getting injuries. So if you are suspecting any spinal cord injury to the patient, you have, for opening the airway, you have to follow the jaw thrust maneuver. And normally we are doing the head tilt chin lift maneuver. So if there is any spinal cord injury, it is important that you have to follow jaw thrust to open the airway. And we have to stabilize the patient cervical spine by using the cervical collar. So you can see while ambulance people, they are shifting the patient to the emergency department, they already used the cervical collar for the patient and immobilize the patient, stabilize the patient. So use the cervical collar for that. Then for cervical injury, we are in the hospital wise, we are doing the hollow traction and all skull tongs and all we are using. And while using the hollow traction, the weight should free hangly, same like all other traction. The weight should free it should hang freely, and hyperextension of the neck also will be there in the hollow traction. And regarding any respiratory issues we discussed here, if any respiratory issues there, we have to provide the respiratory management like incentive spirometry, then ABG monitoring we have to do, and deep breathing exercise we have to tell to the patient, then oxygenation, ventilation, everything we have to take care of that. And if there is any DVT management, we have to provide to the patient anti-embolism stockings, and you have to measure the calf and thigh circumference, you have to measure. And we have in the hospital nowadays, we have the pneumatic compression device, PCD device is there for the DVT pump, or we are calling it as DVT pump, that also we can use for the DVT management. So these are the things it is coming under the complete spinal cord injuries. So now we can go through incomplete spinal cord injury. What are the incomplete spinal cord injuries? Now we can see the incomplete spinal cord injury syndromes. There are more syndromes under this incomplete spinal cord injury syndrome. The first one is central cord syndrome, anterior cord syndrome, posterior cord syndrome, Brown-Sequard syndrome, cordus medullary syndrome, and quada equina syndrome. These are the incomplete spinal cord injury syndromes. So in this central cord syndrome, there is a loss of motor function in the upper extremities, but all sensations it will remains intact. Loss of motor function in the upper extremities. And anterior cord syndrome, pain and temperature sensations are lost, including the motor function it is lost, but the tactile sensations remains intact in the anterior cord syndrome. Posterior cord syndrome, all motor functions are lost, but all sensation remains intact except vibration and touch. Brown-Sequard syndrome. Now we will see what are the incomplete spinal cord injuries. So under that we have so many syndromes. The first one is central cord syndrome. Central cord syndrome, it is affecting the central cord. So what will happen if it is affected in the central cord? There will be loss of motor function in the upper extremities, but all the sensations it will remains intact. Okay, loss of motor function in the upper extremities. If it is to the anterior cord, if it is affecting to the anterior cord, what will be happening here? Pain and temperature sensations will be lost here, and this motor function also lost here. tactile sensations remains intact in this anterior cord syndrome. Next is posterior cord syndrome. Posterior cord syndrome also, the motor function is lost. All sensation remains intact here except the vibration and touch. Then next is Brown-Sequard syndrome. Brown-Sequard syndrome, it occurs due to some of the penetrating injuries. So it will be causing loss of pain, temperature and light touch on the opposite side. These all sensations are lost in this Brown-Sequard syndrome. Next is Conus medullary syndrome. Conus medullary, it is the due to the damage to the lumbar nerve root. So the bladder and bowel areflexia will be there. There will not be any reflexes to the bladder and bowel. So the constipation and urinary retention, everything will be happening as a complication of Conus medullary syndrome. So any question asked regarding the Conus medullary syndrome, you have to remember like there is a bladder and bowel areflexia is there. So related to that areflexia, the complications can be happen. And complete loss of motor and sensory function is happening in the Conus medullary syndrome. That's why this is little bit dangerous. And quadraequinus syndrome, the damage to lumbosacral nerve. Okay, damage to lumbosacral nerve. And also same like the Conus medullary syndrome, here also bladder and bowel areflexia will be there, and loss of the lower extremities, lower reflexes, or all the reflexes will be lost here in the quadraequinus syndrome. So these are the incomplete spinal cord injury syndromes we can see. And next we have to see what are the surgical management for this spinal cord injuries. The spinal cord injuries, the management, we are doing the spinal fusion. Okay, spinal fusion, one surgical name, and you all heard regarding the laminectomy. So decompressive laminectomy also we can do in this spinal cord trauma. Medications, especially they are providing the steroids, especially we can say the dexamethasone to reduce the edema to the spinal cord area, injury area. Then they are giving the plasma volume expanders, example is dextran. Then we can provide the muscle relaxants, that is baclofen and dextrosine and all we can provide as a muscle relaxants. These are the management. Apart from that, nursing management already we discussed in the complete spinal cord injuries. So today's our session is going to bind up. I hope all you understood regarding the spinal cord injuries, complete injury and what is incomplete injury, what are the management for that, the complications happening due to the all the injuries. I hope all you enjoyed the session. Thank you.